was trying to get this right. Okay. Did it just go green, or is that just on my screen? Okay, I don't know why it does that. Anyway, let me see if I can. There we go. Okay, so some objectives for today. I really want to explore how we're looking towards our youth and how we're really thinking about bringing them into what, of course, we call the pipeline into healthcare, and really how that can be a proactive opportunity for people like ourselves in academia, in healthcare, and how there's actually some good examples, including, to brag, yes, my nonprofit, although, you'll see kind of how we differ and how I like to group together. Again, this was kind of a new approach for me to pull this together. I'll also share a lot of my own kind of lived experiences of how, honestly, like I said, pulling this together from being a student leader in SNMA when I served as national president back in 2005 to actually founding the nonprofit in 2012 to being in front of you guys now 10 years later, having actually worked with a large number of students. So that being said, absolutely no disclosures, just to be official. So let's actually take the step back away from the conversation of diversity and really frame out what we're trying to approach, what we're trying to address, really. Framing this out, the problem statement, point blank, and I am not the type to preach to the choir or to sit here and go through the ridiculous amount of data that's out there around health disparities. We've seen it. It actually still disgusts me that we still have to prove to people that this exists and that we continue to see, talk after talk kind of outlining disparities. They do indeed exist. The terminology is rampant and differs, but at the same time, I think there's like some key highlights here that are worth recognizing that a great deal of these disparities, while of course they're directly part of the healthcare that we practice, the treatment, the prevention, at the same time, there's a significant social perspective to this that I think it's part of our dialogue now, it's part of our discourse, but it's not necessarily something that healthcare as an industry is best suited to address, unfortunately. And I think we all recognize, even, through I still consider it short, but my career, now, of course, we call these social determinants of health, but just the broader perspective that the outcomes for our patients are impacted by something broader than just the biology that we're treating. And I think, again, I don't think this is to the point of us needing to prove this any longer, but indeed that we are facing the need to find solutions around this. So we recognize and absolutely love this from the Kaiser Family Foundation, that from a standpoint of wanting to achieve well-being across the bottom, broader healthcare, not just improved outcomes as we measure them in medicine, but that broader concept of health and well-being and functionality and broader engagement with society. I think obviously there's a recognition, again, that our approach in healthcare is quite limited, and that there are social and economic inequities that impact every single perspective of what we're trying to treat, what we're trying to address. Racism and discrimination, though, they're across in gray, really girding, unfortunately, all that we do. And hopefully, you guys were just as excited to read the issue of Health Affairs that came out this week that I thought just brilliantly got to the core of the issue for different communities and different issues. But the overview article on structural racism, I thought really took it to the core, where they were really talking about structural racism operating through laws and policies that allocate resources in a way that disempower and devalue members of racial and ethnic minority groups. I think in taking that definition or outcome of what structural racism actually creates, what it actually leads to, is actually what girds the same exact approach to why we need to be having this conversation about diversity, about our youth, about how we actually need to be thinking about recruitment, that there are structural reasons why we aren't seeing greater numbers applying or even prepared or matriculating or promoting and retaining in medicine. And that the same exact approach to healthcare is what we need to be looking at when we're talking about diversity in the workforce. But to take it even a step back, there was no more blatant environment where I saw, just this set of outcomes and the impact there when I was working at Cook County Jail, my first position out of residency, usually not where a lot of the young docs are jumping towards, but I went in just like head first and absolutely felt that there was the best opportunity that I could see to treat the most marginalized of communities, which is those who are justice involved. And really every single inequity and disparity that you could possibly think of are impacting, of course, mainly the gentlemen that I saw. I mainly stayed in the male divisions. I mainly was kind of minimum and medium security, but just the concept that they were on a path that was totally driven by social reasons, but it was directly impacting their healthcare, their well-being, their future, with every decision they made, every outcome they had, every interaction I had with them. I thought it was even honestly more emotional for me to recognize that there was little that the system was able to do, even though I was, putting Band-Aids on things, treating hypertension, treating asthma, doing INDs in the emergency room. It was completely almost a pointless situation. And so with that, then dug in even further, I was actually even able to take on a more vulnerable population, even within that vulnerable setting, which was the transgender community. I was able to help stand up and create some policy around these patients that thankfully I was able to also clinically treat. And part of just the, I would say, accumulation of the issues that we saw is that we then tend to ignore even the vulnerabilities within these vulnerable communities. So I just wanted to point out indeed that, like, again, the social disparities, the healthcare issues were impacted by those social disparities to the point of just absolute inequity in everything that we saw within the jails. And it translates into our communities to this day. So how do we actually address health disparities if we really continue to promote more traditional solutions, which is maybe some population health opportunities, maybe just thinking about ways to address disparities by providing equal treatment. And I think many of you have probably become more familiar with the concept of addressing equality versus equity. But our approach to this problem statement is, of course, to recognize that we need to value everyone and that we need to honestly have specific interventions in order to reduce unjust differences, and that the same sort of solution is in no way appropriate, and that we need to target that care for that transgender patient that I saw in Cook County Jail, because in no way, if I was able to treat all inmates the same that I saw, would I be able to address her issues. So that being said, we know we need to have specific solutions. We know we need to look at specific populations and really come to terms with how their social determinants, their larger position within society needs to be addressed. What's one tactic to actually address that? The argument to tie it all together, to finally get here, is diversifying the healthcare workforce. And I found this graphic, like, my goodness, I thought it summarized a great deal of work in this space, but that in order to actually address healthcare disparities, in order to promote health equity, one solution, one tactic, in no way a panacea, is our ability to diversify retain, and I would add promote people from diverse populations within our workforce. What does it actually achieve? What are the advantages? Hopefully you're aware of it. I mean, the data is rampant. It is throughout, of course, unequal treatment, the IOM report, but that diversifying the workforce increases trust. It actually increases the communication when you see race concordance between workforce and patient. It actually increases adherence to treatment plans. So it's not the feel-good argument. It actually is approaching a solution for health equity. But yet, even as recently as 2018, the latest data set coming out of AAMC, we're not in any way systematically addressing this issue. I think individually, sure, there are those of us that mentor, there are universities that have outreach programs and the like, but across the board with about 5% of active physicians shown on the right being Black or African-American, we're still only matriculating 7.1% of the class as Black or African-American students. How are we actually going to make any gains if we continue to have the same tactics? Clearly, we need to approach this differently. And clearly, we actually need to recognize the same exact graph that we look at when we're talking about how we're addressing health inequities. We also need to recognize that those same social concerns are what are driving the underrepresentation of Black and Brown students matriculating in anywhere along the pipeline. That for the very reasons, in fact, last night on a set of workshops, we're in the midst of evening workshops right now on the tour. The questions totally came from this direction about how they're actually able to step up when there's cost differential between how they can actually pay for MCAT classes and how they're actually paying for flights to go to interviews and how they're actually interacting with the healthcare system, because how can they actually get shadowing if they don't know any doctors, if they don't have exposure to healthcare? Thankfully, they're interested enough to attend our workshop. I'll give them that. But when they have difficulty with early childhood education, they have difficulty having appropriate study skills and interviewing skills and approaches to actual education in the formal sense, how can we actually expect them to then take a seat on this path into healthcare when they're facing the same exact inequities that their community is facing with regard to their actual clinical outcomes? So the pipeline metaphor is one that of course is out there, that we've got this leakage at every step along the way, starting as early as middle school, when they're actually, perhaps directed away from the STEM classes, or when from an advising standpoint, absolutely nothing wrong with this, but when we're looking at the end product, they're directed towards vocational school and things like that. Same in high school, again, directing them away from perhaps the more strenuous classes, the AP courses, and on and on and on, to the point where, of course, where many of us are now as faculty, and where are we with the assistance and the mentoring and the direct really feeder into different leadership positions. We're having conversations in the tour. Do we even really want to continue with this metaphor, because it has such a negative connotation that we're losing students, that they're dripping out of this pipeline? We're actually having conversations that we should really picture this as more of a highway system, where students perhaps can have different exits off of the highway, or they may have certain barriers. Maybe a tree falls on the highway, but they actually can have some autonomy to figure out how to overcome those barriers. Maybe they get off an exit and they can come right back on. Maybe they can actually build a bridge over a barrier and have some ownership about how they're going to stay on that highway, or maybe even be assisted by a mentor. Maybe they can stand on a mentor's shoulders in order to get over that tree, that barrier in the road. That's just one metaphor, one image that we're discussing. But, this concept that students are lost there in those puddles, we actually don't like. We actually think we should take a more proactive approach to how we're actually looking at our future and taking care of our future. So we actually think there's plenty of opportunity, and now is the time to really encounter all of these kind of negative attitudes, even what I was discussing as far as the leaky pipeline and losing students. It doesn't have to be the reality. Yes, students have needs, but we can actually meet them. We can provide them with support. It's not about a handout. And it's the same exact parallel to when we're discussing social determinants of health. It's not about a handout. It's about actually providing them the resources that they need to be well, to actually achieve and to stay on this highway, on this path, on this pipeline. So really breaking it down into kind of four areas of really progressing assistance and programming. I hope to kind of talk about a few examples of how at each stage there is work being done in this effort, that we first engage them. They have to understand what they're getting into. They have to be exposed to it in the first place. And that's a major gap. Recruitment. Then they need to actually understand the steps that it takes to get into those fields. Engagement and recruitment, distinct areas that we need to distinguish. And we need to recognize that these are not age-related audiences, that actually, you know, at any point along someone's career path, could they be engaged? Retention, of course, making sure that they're not only matriculating into medical school, but actually, you know, moving through that path and not feeling that isolation that unfortunately we hear from a lot of students. And then sustainment. I mean, those of us in faculty, how are we actually continuing in this field? We're seeing, of course, the great resignation and retirement that's impacting so many of us from communities of color, so many of us as women. How are we actually addressing those issues? We have to think along that entire path if we're thinking about diversity, and it's not just this singular approach, but really one that is connected and that requires significant resources. So as far as engagement, the Tour for Diversity in Medicine, again, I just have had so much fun over the past 10 years doing this program. We are now about 48 mentors, we call ourselves. We really try to reach the students where they are in different ways. So when we were traveling, of course, we've been to 27 states now. We've had more than 3,000 students in our program. The idea is that we're an exposure program. We're engaging them, kind of short burst programming. It's meant to be motivational. It's meant to be inspirational. It's meant to just steer them looking in a specific direction. This is where the leadership development can actually start, where they see those of us who are actually running programs like this. Again, that's why I emphasize, I came up with this idea as a student. Like that's absolutely what we should highlight, that it's not something that's got to be established and, you know, with a president or vice president sort of title behind it, but that it can be something that's more grassroots and that they can take on. We should be promoting them to understand that the earlier, yes, but really more the earlier that they engage, regardless how old they are, the better. And so I just I show a couple of images here of different programs that I consider kind of engagement and exposure that we've been involved with. National Pre-Med Day, it was actually a really fun one last year. That's a separate organization run by our friend Ryan Gray, where we did a select number of workshops and participated as the tour. But then we ran a separate program, BIPOC in Medicine, with the Texas Health Education Service. We did a set of workshops about what osteopathic medicine was, and really making sure that we're highlighting more than just what would probably be the traditional fields, but that we need to focus on broader concepts of healthcare, that not every student is going to go into medicine, that not every student interested in medicine may be young even. So we're really reaching out to those non-traditional audiences. And that's why I like lastly to highlight Health Professions Week. They're actually about to start their spring event, which is actually the entire month of March. So it's more than Health Professions Week. But it's actually multiple organizations. I don't know if any of you are aware of it. ExploreHealthCareers.org is the overarching organization, but it's every health profession. They've got the respiratory therapists, they've got the physical therapists, they've got every organization involved, and they're hosting workshops throughout this 1 week, and they're repeating it and expanding it for the month of March. But that for us is a pretty important outreach effort where they're actually reaching out to host the chapters. And so it's high school based, and there's some college students attending as well too. But the idea is exposure early, engagement, just so students literally can say, that's something I can do. That's actually something that I see myself in. I see myself in you. And that's actually one of the data points that we collect on the tour. We try to make it as academic of a exercise as possible. We do pre and post surveys, and really the evidence does show that at least our program is one where they feel positively motivated to at least consider this field where they didn't before. The next stage, again, of recruitment. And so we've really focused on kind of the tactics of the application process. So let me introduce myself, hashtag let me introduce myself is our programming around interview skills, mock interviews. This is not something that comes naturally to most people, but we need our students to be more comfortable in talking in these sort of settings. And we started doing more virtual interview coaching and things like that. Our good friend, Sunny, I hope many of you know Dr. Nakai. We love promoting her pre-med prep book, just outlining as a pre-med advisor and then admissions dean, how to actually look at the application process. Pipeline mentoring program is actually part of the Student National Medical Association at the national level, a different webinar series, just really, again, understanding what the steps are, getting them into the application process, getting them immediately thinking about their path. And then lastly, the mentoring and understanding the day-to-day experiences. I actually still see this as part of recruitment, that it's more than just, oh, healthcare sounds great. Oh, being a doctor sounds great. Let me hear what the day-to-day experiences are so that I understand maybe where I'm looking, pediatrics, surgery, OB-GYN, things like that. And so that's where, our friends, Steve Bradley at Black Doctors Podcast, Dr. Dale, I did the interview. I think I was the first or second woman to interview on the podcast, Black Men in White Coats. I was like, why am I here? But it was fun. But just the idea that we're sharing our stories, that's one of our biggest things on the tour as well, too. This is not about just putting information out there that they can find on the web or that their advisor can tell them, but about telling our personal stories, day-to-day experiences, what mistakes we made, what lessons we've learned. That to us is kind of direct recruitment strategy. So we were happy to have published a couple years ago in Academic Medicine some of the outcomes of both our focus groups and some of our quantitative data on the tour, with really grouping into 4 areas of the feedback that students gave us as to what their barriers were, what caused the leaks from that pipeline, those trees that fall in the highway that we're changing our metaphor to, what do we actually need to address? And the 4 groupings there, sorry if it's small print on some of your screens: inadequate institutional support and resources, limited personal resources and social or family conflict, lack of access to information, mentoring and advising, and societal barriers, work-life balance, difficulty in the job market because they actually have to balance working as well as their education. This was just, we were just so proud to actually get this information and learn this, more importantly, from the students that we met across the country. And we're going to continue, hopefully, in our next tour when we do actually get back on the bus. That's what we call it, hashtag back on the bus. When we actually do start traveling again, we're hoping to start looking at solutions. And eventually we need to be tracking these students longitudinally. We just haven't had the resources. We're a nonprofit, but have absolutely no staff. We're running this on our off hours as we're all practicing physicians and dentists and pharmacists. So don't mind us. We just are doing what we can to track this, and eventually we'll maybe get some research assistants or something to look at this long term. But we were pretty proud to actually get this into these 4 areas and actually have done what we can to really tailor our curriculum, our workshops, to address a lot of these issues. Societal barriers, a little bit more difficult, but at least we know now to share our own stories on the tour so that students can learn from our own experiences. That's what this data really showed us. This is one of our like pride and joy, and let me try to interpret it for you. What we did was really outline and compare another very prominent pipeline program that I am not going to name, but a very prominent pipeline program. We were specifically looking at where they were pulling their students from. How were they matriculating students into their program? We looked across the actual SAT scores, how these students were actually completing school and graduating, whether in 4 years or 6 years. That other pipeline program was mainly green. We were talking literally to an audience, the way we describe it, of students that were succeeding through that path. That's great. We need them to. I'm not denying that. But you might even then describe it, if you extrapolate it out, that these students were going to be successful and that we were recruiting them into a pipeline program where they were most likely going to be matriculating into medical school anyway. I mean, it's a stretch, but what we're trying to argue is that in order to diversify the workforce, we need to be going to find those diamonds in the rough. We need to be going and understanding what's happening on these other campuses and reaching out to students. If you're going to diversify, you have to move away from the solutions that we have in place, because again, it's not working. So this is actually the snapshot of the schools that we've done our tour at. In red, they're below national average on SAT scores, retention rates, graduation rates, both at 4 and 6 years. We are purposely targeting these schools to find those diamonds in the rough, to meet with their advisors, to talk to them about mentoring, to talk to them about post-bac programs, about what to do in order to get onto that pipeline, onto that highway. So for us, we also really want to make sure that we emphasize to these students that mentoring, advising are critical pieces to this, that they can't do it alone, that their school isn't going to be the only real road to success. But for us, it's about reaching those students that really need us. So we were kind of proud when we did this, just again, because from a pipeline standpoint and from a change in solution standpoint, we feel like we're making an impact. Now, again, I don't have the data of how our outcomes are. I don't know. I still need to look at how our students are actually applying and graduating. We're going to do that at some point. I have boxes of data and everything that still needs to get analyzed. But at least from a programmatic standpoint, we think we're making a difference by targeting different audiences in the first place. The next step as far as retention. So the pipeline obviously doesn't end when you get into med school. I mean, clearly, there's issues all along the pipeline, and retention and promotion in medical school and actually getting our students into residency are just as critical. We're really proud to have finally stepped into this space. We're traditionally just a high school and college program. But during the pandemic, we really recognized that first summer, right? I mean, remember 2020, it was just chaotic and we were all in this Zoom world, and all of the medical schools, including your own, I'm sure, were like, okay, we're converting to virtual interviews. That is a massive adjustment for a lot of our students, for all students, but we wanted to make sure when we have students that are potentially disadvantaged in the first place, how do we actually address that? So what we did was build out this new program called Road to Residency. We've done it now 2 years in a row. We work with SNMA and LMSA and offer mock interviews along with a series of workshops to graduating fourth year students in both organizations. General workshops around the ERAS process and the like, then specialty specific. So I run the family medicine workshop. We do all 20 some workshops. 20 some specialties. It's massive coordination, but it's great. First year we had about 200 students participate. This past summer, 2021, we have 450 students and all of the matching faculty. I mean, just increasing droves of faculty reaching out from around the country to help these students. And they schedule then mock interviews with each of these students and help them really think through how they're applying, maybe even reviewing their personal statement, totally voluntary, and reviewing their CV. Resume at that point, it's usually not that deep, but we're really proud of the Road to Residency program. That's our first ditch into kind of the medical school life. And then we were proud, American Academy of Pediatrics had a new grant program, their pipeline grant program, small amount, but extremely important. We stood up a longitudinal coaching, kind of group peer coaching program that we call Pediatric Mentoring Circles. We did 2 different cohorts, one with pre-med students in the fall, medical students in the spring, and we matched them with our pediatric faculty that we have on the tour. And they do large didactic sessions followed by small group sessions on a monthly basis. And it's really about introducing them to pediatrics, introducing them to the practice of medicine. We partner with the Association of Pediatric Program Directors for the medical student cohort. It went phenomenally. We're repeating it. We got re-awarded. We were the only program, the only nonprofit that got it. It was all other residency or hospitals that got the grant from AAP. We were re-awarded, happy about that. And we're going to be starting that program again this spring. I'm actually happy that I got to challenge my own academy, FAAFP. We're going to start family medicine mentoring circles, and I'm trying to convince psychiatry to do the same. But just these cohort training, pre-meds, med students, we might actually start mixing the students so we can actually have kind of that longitudinal peer coaching as well. But that sort of retention of understanding that medical students need that step up as well, that mentoring, that coaching, that preparation is just as important. One of our posters, actually, that we got into one of the AAP meetings last year, just talking about our pipeline mentoring circles and how we're more likely, when at least we were in person, to visit public schools as well as community schools, community colleges. That's actually one thing I didn't raise. When I was talking about kind of where we're targeting our students, we were one of the first pipeline programs that actually were targeting community colleges and really working with those advisors to have programming in place, mentoring in place to have the students recognize how they could actually move on to the 4-year institutions and move on into medical school. Increasing number of students matriculating through AAMC. So the allopathic schools are showing credits, if not degrees, from associates programs. And when you're thinking about diverse populations, why aren't we targeting more community colleges? I mean, this is, I think, one of the more obvious. And there's other work in this space. You know, our friend Efren out there at Altimed in California published a phenomenal article on targeting community colleges as well, too. I think, you know, part of what we saw, the students that we recruited into the circles was purposefully targeting those students in the pre-med space. And it was pretty successful. And hopefully we'll be able to show some outcomes because we're going to be following those students long term. And then lastly, Sustainment. I mean, these are some of our fabulous programs, including Dr. Sanchez's own in BINGAP, but the idea is that it can't stop there. We obviously need to look at the promotion within academia, section chiefs, division chiefs, chairs, vice presidents of hospitals, but we need to be looking in the business side and the operations side and the research side. This is not just about putting us in equity positions, but throughout the really scope of healthcare and hospital operations, I would say. I'm pretty proud at Cityblock to really be pushing for that as well, too. The concept, again, diversifying the entire workforce, maybe not even just patient facing, is what's actually going to allow us to address equity. To just drive it home, National Academy of Medicine, there's the report that they released, I think in 2020, just quoting, the majority of interventions to increase underrepresented minority participation in medicine have been undertaken within the existing systems and structures of academic medicine. We need those new and innovative tools. And hopefully I've described a few, again, meant to be really more, we consider ourselves grassroots, but I think there's a way to really establish this type of programming and get it away. I have to say, get it away from academic medicine and get it into the communities, onto the campuses where our students are. That actually was a foundational piece to when we founded the tour, that we were not going to just bring students to us. Because typically in our workday or in our efforts in academics, we really just reach out to almost what's immediately around us, the high school across the street, within our own city. We need to be going to those HBCUs and those Hispanic serving institutions. We need to be going to tribal colleges and reaching those students that don't have the exposure and helping them, helping their mentors, helping their advisors figure out different opportunities. Again, traditional, regular approaches are not going to be a success. So with that, I was just going to talk a little bit about my personal story, but I know, JP, you also wanted to maybe turn this into something more interactive, and I am totally not looking at the time. So I'm happy to open up a conversation here. I'm also happy to just keep talking. But Deion, I'll leave it to you to maybe help direct us a little bit.
Okay. Thank you. I just want to remind everybody on the call to fill out the post survey, and then I'll let Dr. Sanchez speak briefly. But Dr. Matthews, we have one question in the chat. Does Tour for Diversity promote medical research?
Hands down. Actually, we did a great workshop, actually co-sponsored with the Biomedical Careers Program up at Harvard on, that was more applying to MD, PhD. That's really specific. But yes, we actually have a handful, including JP. JP is officially a mentor, even though he says he never wants to travel with us again because it's so exhausting. But we really do try to promote the importance of academic medicine on the tour, as well as community health. So I have another family doc that works for the Indian Health Service. I myself have been through, community health centers and the like. We also honestly promote, military medicine as well too. I formerly was at the VA and really try to promote that as an option. We have Navy, and actually we have a Navy officer on the tour, one of our pediatric surgeons. That's the other thing. We try to be as broad as possible. So we have allopathic, osteopathic, podiatry, pharmacy, and dentistry that we promote on the tour. And we're trying to expand to optometry next. But the idea is to show them all the options. And unfortunately, those options aren't always visible on academic campuses. So again, it's really trying to get outside of the normal exposure route that we see in academia. But we talk about academics, yes, in answering the question.
All right, Dr. Sanchez, did you have an idea of how to make it a little bit more interactive at the last few minutes?
Well, I just want to go back to one of Dr. Matthews' statement about it being exhausting. It was, but let me tell you, it was one of the best experiences of my life. And I got to spend a lot of time with Dr. Matthews. I think what people may not realize is literally what she does with her colleagues is pull together people across health professions, right? So this is one of the few, I think this was one of the first opportunities, one of my first interprofessional opportunities. So you go out with 10 or 12 others from dentistry, pharmacy, podiatry. And every day, right, you're on a bus traveling maybe 6 to 8 hours, going to a different school. In the morning, you wake up early, like 6 or 7 a.m. And I am not a morning person. You unpack the bus, create a health fair, talk to students for 6 to 7 hours. And remember, these students are hungry. It's sometimes the first time that they're meeting individuals. And you're not only there talking about your area, right, which is medicine, in my case, and public health. These students are asking about everything. And Tour for Diversity does a pre-training so that you have a better understanding of what it is to apply to dentistry, what it is about applying to nursing. Then at the end of the day, before having dinner, you repack that bus and probably travel for another couple of hours and you debrief. So, it's an intensive experience. I think it was more awake time than actually I spent in residency. But that being said, I encourage everyone to experience it. You don't have to be a graduate student. I think you even had some professionals, health professionals. And I think one of the unique things that Dr. Matthews mentioned is that it's all about going to people's communities, not expecting people to come to us and then asking, why haven't our numbers changed? Right. It's about going into the communities and really talking to students who often don't have those health professionals in their family. They're not their parents. They don't have the uncles or cousins, right? Unlike other individuals who have historically served within our classes. So with that, despite what she says, I will go back on another tour and come to New Mexico. But I turned.
We were in Albuquerque. We did come to New Mexico.
Oh, you did?
Yeah, Albuquerque was 2014. Oh, it was amazing. It was amazing.
Well, you just got to come back. That was like 7 years ago, 8 years ago.
It's been a while. So Albuquerque was actually our first community college. We were at Estrella Mountain Community College. It was unbelievable. We've had more engagement there because these students are so eager and interested. It's just, we tend to write them off because they're not the traditional ones. We think they're not on the path to medicine. And it's not the case. We want to build out a broader set of curriculum to potentially, we've talked about, do we set up some sort of summer program for community college students, in particular and partner with the university to really build out, perhaps some sciences, some preparatory classes to actually get them on a path to the 4-year college. Because that's the connection that we tend not to do in academia as well, too. We tend not to think of community college students as moving on. But again, increasing numbers with degrees or credits, at least, coming into medical school. I'll say a couple of other points about our model. We really do try to emphasize, JP, you said it, it's not just interprofessional. We really try to show them the full gamut of professionals, meaning at different stages in their career. So we bring students, residents, fellows, and young practicing attendings. We actually try not to have kind of the, old stodgy professor sort of model standing in front of the students saying, you just need to study sort of thing. Like, we actually want the engagement that a medical student, in fact, our best mentors, we call them, are the ones that are in medical school saying, I literally just applied last year. Let me tell you what it was like. They go crazy for that. Also, you cannot engage with this generation of students. I don't know what we're on now, Generation Z or something, without being on social media. So I don't even update our website anymore. Students that age don't look at the web. They look at social media. So we are doing IG Live. We're doing, everything, possible through Twitter. And, they're not even really on Facebook anymore, but we keep that up to date. The idea is to meet them where they are. So we actually, during our workshops, say, don't raise your hand, tweet us a question, and we'll either answer it live or we'll answer it so that other students can read it on Twitter. Part of it is to engage where they are. So we're reaching them physically, but we're also trying to reach them virtually in the same way. And when I say young practicing physician, I'm about to step out because I'm not that young anymore.
I want to encourage the group, after we've had this discussion with the last few minutes we have, to kind of share their thoughts. And in particular, I know we have Dean Goodwin on the call. If any thoughts have come across that you would like to share or discuss, and kind of have this more as an open forum for the last few minutes.
I appreciate you asking, and JP's absolutely right. JP's been wonderful working with over the last year or so. I think most of those, everything you were talking about for medical students and physicians applies to my pre-pharmacy students, my pharmacy students, and my pharmacists. And I haven't had a chance to work on the tour for diversity. But we do work with HOSA. We have early assurance programs across the state in other 4-year and 2-year community colleges. We're working with our branch campuses right now. Turns out the paperwork, the MOUs are harder to get approved with our own internal branch campuses than they are with other universities. I'm still trying to figure that one out. We've done a lot to try to lower barriers for our underrepresented minorities in our class. We've eliminated the PCAT from our admissions program about, I guess, 3 years ago.
Good.
For students in our we did the research. I mean, it didn't show. The further you got along in your training, the correlation was less and less and less. So if it didn't show who was going to be a successful pharmacy student, we don't need it. For our early assurance programs, we also have one here at UNM as well. We pay for the PharmCast application fee with those EAP programs, early assurance programs. The students are assigned as part of our mentoring groups. So they have access to current pharmacy students across all 4 years of training, and faculty members as well. Again, just trying to, you talked about the engage, recruit, retain, and I will admit though, the sustain was something new. And I'm really thinking about what that sustain is, for my faculty. I see Jose Rodriguez on the call as well. He's my marketing manager extraordinaire. He knows, we have a lot of, I have about half a dozen, maybe more, faculty that were my students. I'm definitely the stodgy old professor who gets up in front. So that's why I have Jose to do my marketing. Is what do I know? I have faculty that were my students, 20 years ago. Now they're senior faculty. Some are actually the same rank as me. So I'm extremely proud of, what we've been able to do here at UNM. I love working with the School of Medicine, College of Nursing, College of Population Health, all the health professions. I think we make a difference for this state. And I look forward to continuing that work.
Oh my goodness. If you'll allow me, I'll be bragging and sharing about exactly what you shared even tonight. Because we need to add a couple of more pharmacists. If you got some great ones, maybe to think of to add to the tour, but we definitely promote pharmacy and have some really strong colleagues on the tour that should definitely be highlighting.
Feel free to reach out to me, JP. JP can find me, or you can just find me on the web.
Yeah, let's do it.
And anytime.
Let's do it. I love it. Thank you for that.
Wonderful. Thank you, Dean Goodwin. Really appreciate, your leadership and everything that you've done with the College of Pharmacy up to this point. And I know that you'll continue to do. Does anyone else have any thoughts about what Dr. Matthews has kind of spoken about this afternoon?
Well, I thank you. I thank you again, JP. Thanks for letting me just have the conversation. This was fun.